Assalamu alaikum, Mr. Chairman, ladies and gentlemen. Thank you for this opportunity. I'll be presenting today, when to celebrate your case. So no disclosures pertaining to this case. This is a 75-year-old lady who has, a typical lady with multiple comorbidities, diabetes, hypertension, dyslipidemia. She has obstructive sleep apnea on CPAP at home, moderate restrictive lung disease, GERD, osteoporosis. And she had gastric sleeve surgery in 2019, but she's still 105 kilos for somebody who's 158 centimeters only. She presented with shortness of breath. She was coming recurrently to the emerge, and then she got referred for further workup. She denies any chest pain at any time. So the echo was done, showed 67% EF, a tricuspid valves that was severely calcified, severe AS. And she had a CAG in another hospital. We don't do that routinely unless we see something on CT, but it was normal. She was anemic, but her renal function was okay. We look at this, echo, one of the echoes that are, you could see that a hypertrophied, almost obliterated LV that she presented with. ECG, nothing remarkable. We decided to undergo the investigations for TAVI, and she had a TAVI protocol. We can see that she's on the small size annulus for her weight, but the thing that's attractive is the sinus of Valsalva diameter, especially the right one was not generous. So we had this in mind. The calcification was moderate. Axis, no major issue, calcification as expected in such cases. But, we decided, this is acceptable. Her Euro score was low, wasn't that high, but, because of the age, multiple comorbidities, and the most important is the poor mobility. We decided, this is a candidate for TAVI. She will go for a balloon expandable valve, size 23, full volume. We were going to use the right femoral axis, right pigtail, radial pigtail, no pre-dilatation, and we do almost all of our cases under conscious sedation. And anesthesia thought that, she will be able to life flight, maybe with some assistance from CPAP during the procedure. So this is the aortogram after deploying the valve. It's a high deployment as we wanted. You could see that there is some paravalvular leak, but also notice that there are hardly any sinus of Valsalva. So we decided to stop here and not post, because this is nominal volume. We decided not to go beyond, and we accepted this. We could see on the echo that was done that, the leaflet was opening well, and, there's hardly any paravalvular leak, so patient took up to the monitored bed. One thing to note that during the closure, we had failure of the proglides, both of them because of the obesity. They were caught in the subcutaneous fat. We had to deploy 2 more proglides and then did a post-angio, and it was perfect. There was no bleeding. Patient was shifted to the high dependency unit. And while I was doing the second case, patient actually became hypotensive. They did a quick echo. Sorry, I don't have the images. And it was basically, as we saw, the severely hypertrophied LV. But now it's basically a kissing LV, a suicidal LV, and absolutely no filling of the left ventricle. Immediately, the cardiac ICU team, resuscitated with volume. She responded, did well. And at the time I went up after my second case, patient basically again deteriorated, became agitated, and she was in respiratory distress. So anesthesia, basically, the ICU team intubated her immediately. But before that, she complained of severe back and chest pain. And we did an echo. It was still, the LV was better, but not perfect. So with this pain and hypotension momentarily that she had and responded, I was worried about the access site and maybe there's bleeding, and the pain was actually from retroperitoneal bleed. So after she was stable, we took her out for a STAT CT scan, and we could see that there's no retroperitoneal bleed, no hematoma. It was perfect. So what was the problem? We identified a new pericardial effusion that was not there on the echo in ICU. So on repeat of the echo, we could see that she has a larger effusion now, and basically the LV is hardly filling, and there are evidence of RV tamponade. So I was worried because of the rapid progression. I decided to go for a pericardial window subxiphoid immediately, not to put a pigtail, because I was expecting to have to underdo a repair. I wasn't sure where the bleeding was coming from. I was more worried about annular tear. So we did a subxiphoid drain, 200 cc. She became stable, further stable, and we observed in the OR for a couple of hours, and there was absolutely no more bleeding. This was probably bleeding that was caused by wire or the pacemaker, but anyway, I did not have to proceed. Put a drain, closed the patient, job done, happy. Patient is stable now, went home. Next morning, I called, it was a Friday morning, patient was stable, but not extubated. And the cardiac anesthesia team in ICU said the ABG is not ready, which is not surprising because of our sleep apnea and also the moderate pulmonary restrictive lung disease. So she remained intubated for Friday until Friday afternoon, when then gradually she started deteriorating again. The pressure was dropping, lactate going up, and increased metabolic acidosis. And basically, we did an echo, and you could see now the RV is worse. It's hardly doing anything, and we were surprised. ECG was nothing new. So I was worried, what are the reasons why she's like this? We had to rule out a massive PE. Fortunately, she did not have a massive PE. So what is the reason? We thought about it. Although ECG is normal, to rule it out, we still did an angiogram, because I was worried, a movement of the valve could have occluded the right because of the small sinus. It was perfect. So patient resuscitated again, back to ICU, stabilized initially, went home, and then by midnight they called me that, she's worse, hemodynamics, lactate is going up, and acidosis. RV now is basically just a balloon. What to do? She's 75 at midnight, Friday night. So, I decided not to make a big deal out of it, so I decided to put her on ECMO overnight. So we put her on femoral ECMO with distal perfusion, and this is the most, I've been doing ECMOs for like 20 years, but this was the most difficult venous access. She had no venous femoral access. We couldn't find the venous access. So what you see on the right side, this is an Avalon catheter. This is actually used for VV ECMO, where you have both input drain and inflow and outflow. But I used both of them as a drainage for the neck because the standard cannula for the femoral is too long. She has no neck, basically. I did not put a balloon, as we usually do in VA ECMO, because I really wanted that LV to distend, so that later on she improves. Attempts to wean after 3 days failed. She, again, needed more support for another 48 hours. And she was off, we managed after 5 days to decannulate her. She was off inotropes in another 24 hours, but again, because of the bad lungs. Can I have 1 second more, please? Sorry, 1 minute. This is the last slide. She had, it was difficult to wean, so our ICU team decided to trach her. She's currently off vent, but with severe ICU polyneuropathy. She's moving her head, but the rest of the body needs a lot of rehab. Patient is shifted out of CICU, and we are not celebrating it until she goes home. Thank you.
Thank you very much.